Okay, now we are going to talk about respiratory disorders that are relatively serious. So we'll talk about neonatal respiratory distress syndrome as well as general respiratory distress syndrome and then lung failure. Every organ has a failure state, and respiratory failure is the failure state of the lungs. All right, so we'll start off with what we call ARDS, which stands for Acute Respiratory Distress Syndrome. And in this disorder, we can summarize it by basically saying it is caused by things that enter the lungs that are not air. Okay? Things that enter the lungs that are not air. The lungs are really only able to handle air with inside the alveoli. So if there is anything that enters that's not air, it will mess up the surfactant expression by those type 2 cells. So this can be caused by trauma, pneumonia, circulatory shock, whereby blood flow is reduced to the lungs, biological toxins, so things that alter gas flow, air flow, or near drowning, whereby there's aspiration of water into the alveolar space. And the onset of ARDS, which is something you should remember, is hours after the injury. So it doesn't come on immediately, because what you have to see, if we look over here, there has to be some sort of lung damage, which then causes at the cellular and then tissue level changes to the lungs. So something entering the lungs that's not supposed to be there, increasing the permeability of the capillaries, meaning that things can move in and out of them more easily. So we can have things like fluid leaving or fluid entering. Things will move through capillaries easily because they're one cell thick. So when we have increased capillary permeability, one of the easiest things to leave the capillaries is water. And that water then will move into the functional tissue, the innermost tissue of the lungs called the interstitium, which at the gross level causes stiffness of the lungs and then shortness of breath. So this might be expected if we think about somebody who inhaled smoke or inhaled water, right? It would be difficult for them to breathe afterwards, and they'd be coughing quite a bit. But the really troubling thing is here where we see surfactant being reduced. And remember, surfactant is needed to break down the surface tension of water so that the alveoli stay open. If there isn't sufficient surfactant, then the alveoli will collapse, which makes the respiratory membrane not function normally and makes effort of inhalation very great. So you see that shortness of breath. That's why you see from reduced surfactant a arrow going this way as well. When there is collapsed alveoli, also, not only is the effort of inhalation greater, but also the gas exchange will be altered. So gas exchange will be altered. The other thing at the gross level that you'll see is that when the lungs are damaged, we see fibrosis, specifically inside of the alveoli at the level of the respiratory membrane. There's millions of alveoli in the lungs, so they make up a large amount of the lung volume. And when there is fibrosis in the tissues of the lungs, we see that compliance is reduced. And remember, each respiratory membrane involves a capillary wall as well as an alveolar cell. So we will have less compliance at the level of the vessel and also less compliance at the level of the alveoli. One of the pathologic findings that's associated with ARDS, acute respiratory distress syndrome, is the presence of what we call hyaline membranes. And this is something that is also called diffuse alveolar damage. So in the case that there is something inhaled, there's water or something that enters the alveolar cells and damages them and alters the surfactant secretion, not only do we have surfactant production interrupted, but we also have the proclivity to develop hyalinization of these alveolar membranes. And what hyaline membranes are is really a mixture of dead cells, so injured and dead alveolar cells, surfactant, and various proteins. And they deposit themselves along the alveolar walls, which further is going to inhibit gas exchange. So we get the deposition of the hyaline membranes and then this reduced gas exchange. So here's the deal. When we have the development of these hyaline membranes, not only are we going to get reduced gas exchange, but we're also going to see some characteristic changes which are going to lead us to this onset difference. So in the case of diffuse alveolar damage, or ARDS, we see, first of all, this fluid in the interstitium, again, leading to this lung stiffness and dyspnea because of some characteristic changes that we see due to damage. So we know when there is inflammation, we have fluid that is formed called exudate, right? So let me get rid of this. So in the first 1 to 7 days, we have what's called the exudative phase. So when we have this buildup of hyaline membranes, something forced into the alveoli, that's going to raise the pressure along these pulmonary capillaries, so raise the pressure. And what that is going to do is encourage fluid leakage. At the same time, when the epithelial cells themselves are damaged, the cytokines released from damaged cells associated with an inflammatory response is going to call immune cells to that area. And they release their own inflammatory messengers, their own cytokines. And that encourages even more capillary permeability and then leakage of that fluid into the interstitium of the airspace, into the lungs, right? And we call that edema. And when there is this edema that can't be removed, that's when you start to see these hyaline membranes really pop up. So for these first 1 to 7 days, we have the exudative phase, but then there is possible healing. So after this injury, we can see what's called the proliferative phase, which is going to last about 1 to 3 weeks, and that is the recovery phase. So that's when there is a replacement of first these type 2 cells, which create surfactant, and those will differentiate through a linked mitotic process into type 1 alveolar cells. And the presence of these healthy cells, most importantly, are going to pump this exudate, this fluid, out of the air spaces, and it can be resorbed into the tissue, and then hopefully there's healing. However, if there is not full removal of exudate, including, these hyaline membranes, which can build up, then we have a fibrotic stage, which is when there isn't sufficient healing. If it does occur, it's after 3 weeks. So we've already gone through exudative and proliferative. So if these type 1 and 2 cells don't come back to their full number and full functionality and remove the exudate and all of the leftover things in the hyaline, like the alveolar collagen, then we will see the fibrosis of the alveolar walls and then the respiratory membrane. The thicker that the membrane gets, so we know that that's going to reduce gas exchange because we can't diffuse gases over a thick membrane, right? So it's going to be hard to get oxygen in and CO2 out. So that's going to be decreased. When you have that altered, remember the measure for oxygen in is signified by a V for ventilation, and the measure for CO2 out is signified by a Q, which is flow or perfusion, which is indicative of the blood flow to that region. When gas exchange is reduced so greatly, we can end up getting shunting. And what shunting refers to is blood perfusing the alveoli is normal. So blood is still getting to the alveoli. So the oxygen is coming in. We have ventilation occurring, but we don't have gas exchange, right? There's no oxygen coming over this respiratory membrane, which is thickened and abnormal. However, the blood flow is still going to be normal. It's still going to be a perfused tissue. Blood flow will continue to the alveoli whether or not they're damaged. All right. So in this case, if we have oxygen not coming in, we're going to have a very low number for our ventilation. Maybe it's 0, but our Q is still a normal number. Maybe it's 1. 0 divided by 1 is 0. In shunting, you have a VQ ratio of 0. And basically what shunting is deoxygenated blood moving from the pulmonary arteries to the pulmonary veins without participating in gas exchange. So blood flowing through the alveoli, but not picking up any oxygen. So that is what we refer to as shunting. And you might know that when deoxygenated blood enters the circulation, that is cyanosis. So very early on in other videos, I talked about cyanosis being central or peripheral. When we have more central types of cyanosis, we have these altered VQ ratios. So that's what we were talking about. All right, so this is a messy picture, but let me do my best to erase all of this and give you, again, the bottom line. When anything enters the lungs beside air, especially water, whatever it is, smoke, some sort of toxin enters the lungs, it's going to damage the alveoli, make the capillaries more leaky. We get fluid in the interstitium. We get edema, the lungs stiffen, and you get shortness of breath. We get reduced surfactant, the alveoli collapse. And when we get this fluid in the interstitium and reduced surfactant levels, we are more likely to deposit hyaline membranes, which further reduces gas exchange. The more fibrotic tissue is, and the greater the reduction in gas exchange, the likelihood is higher of us getting deoxygenated blood moving into the circulation without picking up oxygen. So it's deoxygenated, which results in cyanosis. So it starts with something entering the lungs that's not supposed to be there. It does progress if not treated appropriately, or sometimes just it happens. It can progress to full-on respiratory failure or become a chronic fibrotic disease where we see thickening of the respiratory membranes and then reduced gas exchange. There is a pretty high mortality rate, 50% overall. So that means 1 out of 2 patients that experiences diffuse alveolar damage or ARDS is at risk for death. And in older patients, the risk of mortality is 90%. So that goes to show again how important surfactant is, and also how important that we don't get aspiration of anything like water or vomit or smoke into the lungs, messing up the surfactant expression and then moving up the pressure and causing fluid to leave the capillaries and give us edema and then possible hyalinization. All right. When neonatal respiratory distress occurs, neonatal respiratory distress syndrome, it is not so much due to an acute injury that alters surfactant production. Instead, this is linked to maturation of these type 2 alveolar cells. Remember, type 2 alveolar cells make surfactant, and they really don't start their maturation process until about 20 weeks in utero. So that's when they start working, but they don't really reach their full maturation until about 34 weeks. So that means if a neonate is born any sooner than 34 weeks, they are at risk for having immature type 2 cells. So one of the characteristics here is just premature birth. We consider full term to be 37 weeks. That's when everything is pretty much fully cooked, but before 34 weeks, the type 2 cells aren't at their full functioning capability. And without surfactant to keep the alveoli open, we see collapsed alveoli and reduced surface area for gas exchange. We can also see this in full-term infants with mothers with diabetes, which is one of the reasons they test for gestational diabetes generally pretty aggressively during the gestational period to prevent this association from becoming stronger. So if there's high surface tension in the alveoli, remember surface tension is when water associates with other water molecules. We don't want it to do that. We want it to spread out its pressure in all directions. So when we reduce the surface tension, we increase compliance. We decrease resistance. Okay? So high surface tension is going to collapse these alveoli. So these ones have high surface tension. They're collapsed, there's greater effort of inspiration, and poor little neonates that are chronically fatigued. When there is hypoxia in general, you see that affecting not only the tissue of the lungs themselves, where hypoxia to any organ causes damage that can lead to tissue death, but you see this in ocular function as well. So you can see toxicity to the visual system. Just a little note that this is treated with surfactant replacement. So surfactant replacement, and also the not infusion, but the administration of tidal volume. So they'll get oxygen supplementation as well as surfactant supplementation. My little note is that if that level of oxygen in the tidal volume is too high, that also causes, I don't know why I circled that also causes eye toxicity. It causes blindness. However, if that level of oxygen is too low, it causes death. So it's a very specific level of oxygen that has to be given in addition to the supplemental surfactant. It can be really difficult. We can get acute respiratory failure and possible death in 20 to 30% of infants that do present with this. So preparing for prenatal support is really important. There are medications that can rush, essentially, the maturation of the type 2 cells if given prophylactically, but the best we can do is good maternal care to prolong the gestational period. Here's here's a little table for you, neonatal versus adult respiratory distress. It's a pretty good table for you. So neonatal, we see this mainly in premature infants. ARDS, we see that in direct or indirect damage, things that enter the lungs that shouldn't be there. Cesarean section is more common. That has to do with specific pressure changes that occur in the respiratory system when the fetus goes through the vaginal canal, and also in infants born to mothers with gestational diabetes. And the pathogenesis, or the creation of this disease state, is inadequate surfactant, again, by immature type 2 alveolar cells, whereas in adults, the pathogenesis is direct damage due to inhalation of gases, aspiration of fluid, water, vomitus, lung trauma. That can be due to septic shock or systemic circulatory shock that decreases blood flow to the lungs, or anything that would alter surfactant production. Again, treatment in neonates, giving corticosteroids to the mother before delivery, endotracheal surfactant, and infused oxygen, specifically tidal volume, which is the amount of air used in a normal inhalation exhalation. In adults, support circulation and respiration, endotracheal tube and respirator, and positive pressure oxygen to support the system and prevent collapse. Also, whatever caused it, you need to treat it, right? So if it was due to shock, you need to restore blood supply. All right, then finally, as we mentioned, every organ has a failure state. Respiratory failure occurs when the lungs are unable to perform their duties, which is to exchange gases, so exchange oxygen for CO2. And we need to remove CO2 because it is something that is toxic to the body when it builds up. And when there's too much CO2 building up, we call that hypercapnia. When there is too much CO2 building up, you will see things like people complaining of a headache, especially in the morning, headache. And what that is telling you is that there is increased intracranial pressure. So the lungs cannot remove the CO2, can't oxygenate the blood. You can see possible shunting and then cyanosis. In respiratory failure, the lungs are not working anymore, so shortness of breath, difficulty remembering things. If your brain isn't perfused with blood and oxygen, all of the areas that you need to work aren't going to work appropriately. Whatever area is most active, so if you're looking for a memory in your cortex, more blood flow should go to that area because the cortex will need more oxygen to work. In the case where there's inadequate oxygen, the brain will be perfused at a steady level because the body just wants to keep the brain alive. So you won't see the ability to increase for any one thing. Same thing with visual impairment. The occipital lobe at the back of the brain needs more blood flow and oxygen to utilize when we need to look at things and make accommodations with the size of our pupil, looking close or far away. So that becomes impaired. Anytime there is a visual impairment, that includes tunnel vision, blurry vision, double vision, that means the brain is affected in some way. Period. Period. With a T. Period. All right, drowsiness and again that headache, those signal hypercapnia. All right, respiratory failure in general, we have hypoxia, so low levels of oxygen. That's when the pressure of oxygen is less than 60 millimeters mercury. When that happens, we have widespread tissue damage. The kidneys start to lose their ability to function and go into renal failure, which means that we start to retain things that we want to excrete, and that can also cause the retention of fluid as well. Electrolyte imbalance is another thing that can cause that. All right, just a little note I did do because I remembered something. When we have acute respiratory failure, I was clued in by electrolytes. This can have an iatrogenic basis, meaning caused by some sort of hospitalization or healthcare in general. And you can see this in hypophosphatemia and also hypokalemia, the K for potassium, hypokalemia. Those are things that can cause acute respiratory malfunctioning, essentially. The main electrolyte disturbance. Hypophosphatemia or hypokalemia, usually iatrogenic in its cause. Another thing that can cause acute respiratory failure is a maltase deficiency. Otherwise, we usually see more acute damage due to stroke, poisoning due to central nervous system depression, like overdose of different drugs and alcohol we mentioned. It can be also an embolus that blocks blood flow and causes acute lung failure. But then there's also the chronic diseases like COPD, cystic fibrosis, ARDS, pneumonia, and those other chronic things that cause restrictions like the muscular dystrophies, amyotrophic lateral sclerosis, which is an autoimmune disease which attacks the myelin of the peripheral somatic nerve, so the muscle that is skeletal, so the somatic nerves that control skeletal muscle. And remember that the diaphragm is skeletal muscle. And also nervous injuries like those to different levels of the spinal cord. All right. In hypoxic and hypercapnic, we see that the pressure of CO2 is greater than 45 millimeters of mercury. So again, that hypercapnia is retained CO2. It's really important that CO2 be removed from the body. At the biochemical level, you need to remember that CO2 is an acid. So when you retain CO2, that drives down the pH of the body, and biochemical reactions happen in a very tight window. So when you get to a very low pH, biochemical reactions cease to occur. And no alkaline diet is going to fix that. It's just biochemistry, and that's the way life is. So it's really important that we maintain that, because when hypercapnia gets to a really great level, we start to see that Shane's-Stokes breathing, which is these essentially these spastic bouts of hyperventilation, which are interspersed with apnea. And those can come right before full respiratory failure, so monitoring levels of oxygen, but especially CO2. CO2 is an acid. It does alter the pH of the body. And we want to avoid, hopefully, respiratory failure, because that's when we oxygenation of the tissues. And that's it. That's respiratory failure and ARDS. All right, stay smart, everybody. Get full oxygen.